So without further ado, would like to take this opportunity to introduce Dr. William Hozack. He is one of our joint replacement surgeons here at Rothman Orthopedics. Dr. Hozack sees patients out of a few of our office locations, Bensalem, Pennsylvania, our South Philadelphia office, and also our Marlton location. He also has a few different surgical sites based on whether a patient needs an inpatient stay or they qualify for an outpatient procedure. Dr. Hozack, this is an honor. He has been with the organization for a very long time. Most times no intro is needed for him. Many people, physicians alike in the community, know of him and trust their patients to him. So I appreciate him taking the time out of his busy schedule and for all of you that are joining in this evening. And I will let Dr. Hozack take it from here, share his presentation, and I will, again, any questions that come through, we'll ask him during the presentation and or save them for the end. So Dr. Hozack, the stage is yours.
Yeah, thank you very much. Yeah, Bill Hozack here. Happy to be participating in this, and I don't really know how many people are here, but for those that are here, I hope you enjoy the show. I'm going to talk about outpatient joint replacement surgery, which is really, for me, about hip and knee replacement. So that'll be the topic today. As was just said, there are opportunities to ask questions. This talk will not last a full hour. It's probably going to be maybe 20 minutes, depends on how fast I talk. And then there'll be lots of time for questions or any kind of clarifications that you might have. And feel free, any question. No question is unimportant, so feel free to ask, all right? I also want to mention that although I don't travel to all offices that we have, I do also offer what's called telehealth opportunities, so I will see patients. We have a telehealth system set up at Rothman where you can see any surgeon for that matter, but I see patients that way, and we communicate very effectively that way. Actually, I find it very relaxing. The family can participate in the interview, and unlike where some of the places you go, you may be restricted in being in the office with your family member, or with if you're traveling with somebody else, they may have to wait outside. Hopefully that will change someday. So let's continue with the talk. Outpatient joint replacement surgery. I've been doing outpatient joint replacement surgery for over 10 years, so it's not something that it's an experimental thing, but let's see if we can get this going. Okay. I want to first say that kind of like the Wizard of Oz, right? Dorothy coming home, there's no place like home. Home is the safest place to be. While you may think that a hospital is a safe place, actually being at home is the safest place. And we've actually, you're going to see through this talk some publications that I'm going to quote, and these are all from, most of them are from Rothman Institute. We have an active research program, especially in joint replacement, trying to push forward the frontiers of medicine in a safe and safe way. And what we found that patients that even living alone could be going home after joint replacement and be safe. This was published in 2018. But same day, going home the same day, why would anybody want to do that? And I can understand why there might be fear about going home. I mean, traditionally, the hip or knee replacement is considered a major operation. Why would you want to go home on the same day as a major operation? Is that safe? Is that wise? Is that prudent? I can understand all those questions. And this talk is designed to reassure you that this is something that is safe and that we do every day. This is another study that was published in 2017 by us. The award was given by our Hip Society, which is a national society that I participate in, experts in hip replacement. And the conclusion is, in this study, there was no difference in any kind of the parameters you might measure for patients that stayed in the hospital versus patients that went home the same day as the surgery, in terms of any of the parameters we measured. So it is safe, it is possible. And in fact, it's been going on for many years. And this is not our study, this is a publication from Chicago. And in 2005, they published their first studies, and they had been doing it for 3 or 4 years at that point. So, it's safe, that it's not new, And while it may seem scary, at least to think about it, it is not, in fact, a scary experience. And as I tell everybody I meet and some surgeons we talk to about it, it's the new program, right? Get with the program. What is the program? Well, it's for us and for me, it is to standardize the care, the perioperative standardization of care. And that's driven by a series of protocols that we've developed. And to run the protocols effectively, it makes it a safe and easy experience for you. Are you a candidate? And, maybe. I don't know there's any one person that I would necessarily say no to. I mean, for me, the most important single factor in success about patient surgery, that's OPS, is to choose the patient. And I don't have specific age groups, right? But on average, somebody who's younger in health and younger in mind and healthy, who's not significantly overweight, has some social support, those are the ones that I would generally choose. And those that are older, less healthy, and higher weight with no family support might be those that we keep one night in the hospital or 2 nights in the hospital, depending on their medical condition. But again, I didn't put any ages down. I didn't put any what health means, and I didn't put the actual weights and things, because that has changed. That has changed over time as we get better and implement newer protocols and adjust the protocols. More and more patients are candidates for outpatient surgery. Right now, for me, I would say it's between 30 and 40% of my patients that I operate on will be going home on the day of surgery or are eligible to go home on the day of surgery. And that percentage will likely increase over time. I think perhaps the most important factor from a patient standpoint is that they're motivated, that the impossible is now possible. The right attitude is there for both the patient and the family. How can what do we do? What does Rothman do to make this work? And I'm going to go through a series of things, but again, the patient selection is still number one on the list. So what do? We educate you, and we educate both you and your family about what the expectations might be, what the experience might be, and we're pretty good at predicting it, right? We have nurse navigators. These are well-trained professionals who follow you. They pick you up prior to the surgery, communicating you preoperatively, getting together all your medications and instruments that you might need after surgery, like canes and walkers or whatever, and follow you after the surgery for a period of time to make sure that the experience is good. And then there's consistent messaging that everybody you meet in the line of care, from the preoperative experience all the way through the surgery and afterwards, has a consistent message that it is safe and that we will be there for you if you have an issue. Surprisingly, there are very few times that there are issues because of the protocols that we institute. Yeah, I got to control the pain. I mean, you can hip and knee replacement patients, and I don't know what your personal experience might be, generally come in because pain is pretty bad, right? So you come in with pain, right? And we get rid of that pain by doing the operation, but the surgery itself is a trauma, and it does lead to pain for muscular, stretching muscles and things like that. So we have to help you manage the pain. And we do that so much better now than we did 20 years ago. And there's a variety of different medications that we give you. If you're going to have the surgery on a Monday morning, go home Monday afternoon, we give you intravenous medication, anti-inflammatories, steroids, Tylenol. We give you soft tissue injections. That's local anesthetic around the incision. And in selective cases like knee replacement, we use nerve blocks to help deaden the pain. These are all critical factors that give you pain control so that you can go home. And then when you get home, your pain is manageable. We've done a lot of research on this too, and these are 2 separate studies. I'm not going to go into detail, but this is 2 separate studies separated by 10 years, right? 2010 and 2020, about different pain management protocols. In 2010, about how to do nerve blocks in the operation around knee replacement in 2020. So we're always doing continued research to refine and improve the process and the experience. Another study, again, this is a study, I don't want to get too detailed about these studies, but it's about opiate sparing, which is really avoiding narcotics, right? And narcotics are good for pain management, no question about it, but they have some substantial side effects they also are potentially addictive. I'm not so much worried about that because the narcotic use is really short-term for joint replacement, but the side effects are there, like, getting stopped up and drowsiness, and some people get a lot of side effects. And if you can do a multimodal, that is different medication, pain management, that MMPM, the blue column, and that's what we do. We use Tylenol, gabapentin for those of you that may have back problems and nerve pain. You're familiar with gabapentin, an anti-inflammatory. And then we do provide mild narcotics after surgery, given in small numbers for a short period of time. But by doing it this way, we can reduce your need for their narcotic medications and therefore reduce the potential side effects of those pills. We use less anesthesia now than we used to. We've modified the way we do the anesthesia. We use spinal anesthesia for the most part, but I have patients, we do this anesthesia at 7 a.m. and they are leaving the hospital between 10:30 and 11 a.m. having had the surgery done. And it's really quite impressive. And by using less anesthesia, there's fewer side effects of that anesthesia. And again, we've done this with our own anesthesiologists. These are, again, other research studies that we've published. This is from 2020, last year, about different kinds of anesthesia that can allow, if you look at the red bar, what that shows is that type of anesthesia that we favor now allows up to 80% of patients to be walking between 3 and 5 hours after the beginning of the anesthesia, which is very impressive. And, to get up and get going is quite important if you want to go home, of course, but for everybody, in fact. Rothman, I think one of the strong points that Rothman has is we do good operations. And that's really been our signpost for many, many years, as long as I've been a member of the Rothman Institute, which I have to say is I've had some of this affiliation with Rothman for over 40 years now, because I did my training here too. And how do you do what do I mean by doing a good operation? Well, do it quickly and efficiently and predictably, so there's no surprises. Minimize blood loss by doing surgical technique, and that TXA is a special medication we give you intravenously to reduce blood loss. That's a standard of care now. And while doing a good operation, we can allow you to get up and move around without any early restrictions. Again, more studies that we've published about early weight bearing after hip replacement, about avoiding the need for restrictions after hip replacement. So you can get out of bed and weight bear as tolerated, that is, with some support, a walker, cane, whatever you need, and not have to worry about body positioning where you can go in a car or you can get out of the car, you can sleep any way you want. So you can get up and get going. The operative technique is such that we can let you do all these things, which facilitates an easier recovery. We also have done a lot of research into less invasive surgical approaches. These are 2 studies published about 10 years apart about hip replacement approaches, but we also have similar things about knee replacement as well. So, again, everything that we do is designed to improve, reduce the trauma of the surgery, reduce the pain of the surgery, reduce the complications or side effects of the medications, and allow you to get up and get going quickly. And that facilitates the opportunity to go home on the day of surgery. And what do? We get you up and get you going. There's no pain. Well, nothing. I would say less pain. No nausea, no fainting. I'll come and talk about that. No blood loss, minimal blood loss, no restrictions, and updated physical therapy protocols so the therapists are on the same page of us, and they give you instructions on how to get going and what kind of things you can do to encourage you to return to an active lifestyle as quickly as possible. Simple things actually make a huge difference. I mean, somebody, in my experience, a patient who develops nausea or throws up after the surgery is almost guaranteed to stay overnight. So we have, it's just one of those things. It's very hard to think about going home when you're feeling nauseated. So again, the things that we do are designed to minimize those side effects of medication. Fainting, another thing, again, that quick acting anesthesia, using less narcotic, using different kinds of pain medication, properly managing blood loss, all these things reduce the chance of a patient feeling lightheaded, a patient actually fainting. Again, once that happens, it's very difficult to convince the patient that it's okay to go home. And so if we can eliminate those side effects of the medications and the surgery, we can allow you to go home and feel safe. We now have dressings. Well, first of all, we close the skin with glue now. after we sew it up. So it's really watertight, and we use a special dressing that stays on for 1 week. So you can go and right away and start showering and continue with your life pretty quickly. Discharge criteria, again, appropriate, achievable criteria to make outpatient surgery safe and minimize readmission. And most patients who have this operation, who are planning for same day discharge outpatient surgery, will be going home within 6 hours of the end of the operation. So we have certain criteria about what you need to do after the surgery to be able to go home. And I always remind patients, I try to remind them, look, you already know how to do all this. This is not like things you have to learn. You know how to walk, you know how to do stairs, you know how to get out of bed, you know how to get into a car. You just have to be shown once how to do that. And you'll be able to do it. So it's not something, you don't need to learn anything new after the surgery that you don't already know how to do. All systems are go, of course, we talked about that. No nausea, vomiting, fainting, tolerating fluids, perhaps not eating a hamburger after surgery, but something light. And you're comfortable. The pain is controlled. Somebody can give you a ride home, and emotionally you're ready for discharge. It's been a planned event. There's been no unforeseen circumstances. Everything is according to the plan. So now you can feel comfortable going home because everything is as was described. We don't kick you out the door and let you go. I mean, you know, outpatient surgery is not abandonment, all right? We are as actively involved in your care as we would be if you stayed in the hospital, and perhaps more so. And so, you know, it's not like, okay, out of the hospital, out of mind. That's not what happens. We have a clinical staff member. We follow through. I mean, we have a clinical staff member familiar with our protocols and knowledgeable about standard care, who will call you next day, I'll call you before the weekend, and call you a week after surgery. And we have, so, you know, it's the same thing as we would do if you were in the hospital. We would make rounds, but you don't have to be in the hospital to be in contact with us. And again, really not much is happening. It's more about phone calls to reassure that, yeah, a little swelling is okay, a little pain is okay, and it's okay to do what you want to do. But a lot of this stuff is just gentle reminders that things are okay. And again, we provide easy access, and you can make phone calls. There is also electronically ways to get a hold of us, and I don't have all the details about our patient portal, but I would encourage you to make sure you sign up, if you're a patient, sign into that, because you can communicate through that portal electronically so that you have immediate contact with our system. So a much better way of contacting us through the electronic systems. So the keys to success: choosing the right patients probably is number one. Adhere to proven protocols, standardize the care, do a good operation, minimize side effects. Sounds simple, right? Well, it's so simple, actually. All these things we've incorporated into our outpatient surgery program, we now use in our inpatient program. So we use the patient, if you decide to stay, or you need to stay, or it's wise if you're 85 or 90 years old, we keep you overnight. You get the same treatment as if you would have gone home, which actually is the highest level of care, I think. So you get the same protocols, the same treatment. So going home or staying in the hospital, you get the same treatment. It's just where you're sleeping that night is different. But there's more. I don't know how many people are old enough to remember the chamois, but that's my, that was when I was younger, that was the thing that was advertised a lot on the television. But maybe nobody on this call has any idea what I'm talking about, but whatever. You could have outpatient surgery and actually not go home. And what doesn't make sense? And this is one little plug for a type of a system I'm actually operating, and I actually operate it today. Yeah, you can actually have outpatient surgery and not go home. And here's how it works. And it's our MOVE centers, M-U-V-E centers. This one is in Warminster. I operate there today. If you see on the picture on the bottom part of the slide on the right-hand side, there's an MUV center. And this, on the right-hand side of this building is the operating room, and on the left-hand side of the building are what's called the stay suites, where you would stay. And these wonderful suites shown up top on the right, which are like, you know, high-class hotel rooms, and there's high-class food. Doesn't look like a hospital, but the operating room is high-class. And you have the surgery there, and you're taken care in this hotel situation by nurse practitioners and physical therapist for 2 nights. So again, an alternative of a way to, and again, this is another way of doing outpatient surgery, a new twist on the new model that we work with. Again, just another plug for another way to do it. We're always looking for better ways. So I'm done. That's it for my talk. I figured it would be about 20 minutes or so, and that's about right. And I'm open to any questions that you might have. Thank you for listening.
Wonderful. Thank you for that, Dr. Hozack. I'm going to start reading off some of the questions that came through. Are patients without comorbidities on blood thinners before or after joint replacement surgery?
Yeah, so people, I think the question I heard is, if you are a healthy patient, right, are you going to be put on a blood thinner after surgery? Is that what the question is?
Before or after, yes, that is correct.
Yeah, so before the surgery, I'm assuming if you're a healthy patient, you're not going to be on a blood thinner. So we don't put you on a blood thinner before the surgery. But all patients that we operate on are placed on a blood thinner. I didn't put that slide in, but we've done research on it as well and published multiple publications in the highest level journals that aspirin is the blood thinner of choice that we use for outpatient and all surgeries for that matter. There are some patients that come in on blood thinners that we, for other reasons, and we continue them on those blood thinners, but the general healthy population will go home aspirin for 1 month.
We have a gentleman that joined us. He states you operated on him 3 weeks ago. He just wanted to sit in to hear the discussion. He is very happy, and also an FYI, the entire process was phenomenal in its efficiency and effectiveness. He is quite pleased with the outcome.
Wow.
Just nice words there. I wanted to.
I'm glad to hear that. And again, I'm always happy to hear that patients are happy. That's my goal, right? To make a patient happy. But I don't want to be the one that takes all the credit. I sometimes get all the credit, but it's a whole bunch of people behind the scenes doing the work, and also the people that he met in the hospital beforehand, at the day of surgery, and subsequently with whom he's been communicating, who make it work and make it seem so safe, which it is, but it really does work well. It's a big team of people.
A very broad question, and I don't know if they're referring to hip or knee, but what is the normal length of time for full recovery?
Yeah, a lot of patients are very interested in knowing full recovery, and it's actually a slightly difficult question to answer because everybody has a different goal in mind, right? What's your goal, right? So if your goal is, I want to be to a point where I don't even know I have a joint replacement anymore, that might take a year, right? And that's more true for hip than knee replacement, because knee replacements always have some degree, know that they have a knee replacement. If your goal is, I want to be up and walking, that's going to be 3 to 4 hours, right? And I want to go back to work. Some people go back to work the day after surgery because they work from home on an electronic. And other people take 3 months because they're heavy duty, labor intensive things that really require a very full recovery. People that like to play sports, for example, I tell them, okay, if you're playing golf or you're playing tennis, start playing around a month and see how it goes. 3 to 4 weeks, see what happens. And your therapy is to go back to that activity and use your activity as your therapy program. So, but I guess, there's going to be ongoing change for 6 months to 12 months after the surgery, the majority of which is in the first 3 months.
After both partial knee or full knee, when do you allow patients to drive again on their own?
So I'll answer generically and then specifically, because there is some slight variation, I suspect, from doctor to doctor. And I have my attitude. So the answer is sometime in the first month, right? Is the general answer for most patients. Now, if you operate on your left leg and you drive a standard, you can drive sooner, right? Your right leg's not operated on. So that's already a different, right? What I tell patients is, as soon as you feel comfortable and as soon as you feel you can control the leg, you may drive. So some people start driving within the first week and other people wait 2 or 3 weeks, and there's some variation. But so I let them drive as soon as they feel comfortable and they feel they can get from the gas pedal to the brake. And everybody's different.
Can revisions be done in an outpatient setting?
So two answers. One is they are not currently done in outpatient settings, but from my perspective, some types of revisions could be done if they were given the approval to do so. Right now, it's more about getting approval either from the institution, the hospital, or the insurance company to do so. But yes, some can. But in general, revisions are a different level of complexity. And I prefer to do them downtown at the main hospital because that's where we have all sorts of equipment to do it properly. So no, mostly no.
Someone asks, is there any reason to use Tylenol instead of a less expensive 350 milligram arthritis acetaminophen if it were a Rite Aid brand or another brand?
Yeah, my suggestion is use the cheapest one, so Tylenol. And we also, the anti-inflammatory we use is meloxicam, which is the least expensive anti-inflammatory. It's a prescription one. You could use Aleve as well if you wanted to. So yeah, there's no advantage to anything that's non-generic. So generics just fine.
I have another prior patient of yours here. You did a procedure, a knee replacement back in 2002. They have not experienced any knee pain, but occasionally some fluid buildup. Would you recommend they come back in to see you or begin taking anti-inflammatories?
Yeah, I think in general, everybody should come back periodically for checkups, like every 5 years, because these are mechanical parts. And even though they may be functioning perfectly well, it's like, you take your car in to get a checkup, even though maybe it's not making any noise, you got to come in for a checkup periodically. So, it sounds like she may not have been back for a while. I would recommend she get back. Now, if you're having symptoms, so I hear some symptoms, my recommendation is you make a phone call and speak with one of our physician assistant people ahead of time, because then they can talk to you on the phone and decide if you need any special tests ahead of time and get you in at the right spot. So, there's a couple of different avenues to come back, and my suggestion is always call and talk to our people first.
Do you recommend pre-op PT exercises for hip replacement due to osteoarthritis for optimal recovery? This is from a very active senior with bearable pain.
Yeah. So what I tell that person is your activity is your therapy program. So stay healthy, fit, and active. And that's your best way to improve your speed of recovery. You don't really need to do any therapy for the joint when it's painful. When you're coming to surgery, it's usually because it's pretty painful. And therapy on the joint is actually frustratingly ineffective. So I encourage patients to be active and stay fit prior to the surgery as a means of recovering faster.
Where do you draw the line in determining if a patient can have their procedure done in outpatient as far as underlying conditions for high blood pressure, as an example?
Yeah, things like high blood pressure or diabetes, what I consider non-dangerous, if they're treated under control, are not contraindicated, not something that would prevent me from doing the surgery as an outpatient. A lot of it is attitude, patient attitude, and things like if you have a cardiac condition, the anesthesiologist is often reluctant to do it in the outpatient setting. But that's the majority of those that I would not do there. But everybody else, anything that's under control, diabetes, high blood pressure, thyroid, if your weight's under control, all those things under control, I think it's reasonable to be considered as an outpatient candidate.
Another one, as far as being able to be done in an outpatient. I know BMI is a huge factor for us in some of our surgical sites. What are your BMI restrictions on patients for the outpatient setting?
Yeah, so BMI, it is really, first of all, it's complicated because some people who are very muscular, they're artificially high BMI. So it's not but some people are who truly have a lot of fat tissue and are really quite heavy. And I think those patients struggle to mobilize quickly after surgery. So I think they benefit from an additional day in the hospital getting therapy before they go home. So it's not about mind over matter. It's just, I think, the practical choice is to go to the hospital setting and spend one night in the hospital. You don't have to go to a main hospital. You go to our Rossman Specialty Hospital or FICARE and get treated there. We have some guidelines about the safety of the operation. We want, the key to operating for joint replacement is really three things. Is number one, the surgeon does a good surgical procedure, a good technical job. Number two, we avoid a complication. And number three, after surgery, you do some kind of therapy, whether it be just doing things or getting actual physical therapy. And related to complications, as the body mass index goes up, the risk of complications start to rise. And so we've kind of drawn a line, not necessarily a solid permanent line, but around 40 BMI, we tend to start not talking to the patient about trying to do some weight management prior to the surgery to make the surgery a safer operation for them.
I will just reiterate that point that if their BMI is too high, we do have on staff here at Rothman. They see patients both out of a few of our New Jersey locations and Pennsylvania locations. With most commercial insurance plans, you're actually qualified from anywhere to 3 to 10 free dietitian visits a year. So if that's something you're interested in looking into, by contacting your insurance provider, and you can always get scheduled with one of our physicians if you feel that your BMI or were previously told that was too high for current surgery within some of our standards.
Yeah, I'd like to say something on that too. I think that sometimes the perception is that, okay, we see you, you're high, your weight is too high, goodbye. No, that's not the way we like to approach it. We want to treat you properly, which is bring you into our program of weight reduction, as just mentioned. And then when you achieve weight reduction, we can successfully do the operation. And we don't always stick with 40 as we don't, if a patient shows progression from a very high weight to a lower weight, that's a positive contribution to the success of the operation. And we will then consider operating, even though they may not have reached that magic number of 40. So, but we're not going to, we want to treat you as a patient, so we're going to help you try to lose weight, but you need to do that with the dietitian.
Thank you. This one may be a little in depth. What are your post-op infections and plebeius rates within an outpatient?
Yeah, well, actually the infection rates are, less than 0.25%, right? I always tell a patient, look, that's not very helpful when you get the infection because now it's 100%. So statistics are a small game you play sometimes. The selection process is such that the outpatients surgeries that we do are done in the healthiest patients. So they actually have lower infection rates just because they're healthier patients, right? So it's really a selection bias. The patients with significant medical comorbidities who have higher risks of infection to begin with are those that we do in the main. We don't do those as outpatient surgery. So the risk of infection outpatient is actually lower than the standard risk. A lot of that's because of patient selection.
As far as PT post-operatively, do you send patients? And if you do, does anyone have visiting PT come to their home?
All of those are yes, but I'll go through them in sequence because we're not rigid about how we treat patients, but we have a protocol. And for a hip replacement, for example, the protocol states that, your daily activities are your therapy program. So anything you do every day that requires that you move your hip, which is everything you do every day, is a therapy protocol. So you don't necessarily need to have a therapist help you, but there are some patients who struggle, and then we bring in a therapist. On the knee replacement side, knee replacements tend to be a bit more painful than hips and require a little bit more encouragement to get their motion back in the early period. So we focus more on therapy for active, real therapy for the knees. And it can be done with our web-based protocols, which we've shown is effective, but also we prefer that you go to outpatient therapy, get you out of the house. They have better equipment at the outpatient center to do the proper therapy job. But there are some patients who will get home therapy because they need it. It's not the first choice for us.
Another prior patient of yours did bilateral hips in October of 2016. The operation was the fountain of youth. She could barely walk into the hospital and was up and walking a few hours after surgery. She's never felt better. Everyone is listening to the best joint replacement surgeon in the world. Thank you for giving me my life back. And to the point how she mentioned bilateral, is bilateral a possibility in the outpatient setting?
Well, first of all, I'm never going to let a compliment go unthanked. So thank you very much for that compliment, right? You got to make sure you accept compliments because that's helpful. I appreciate that. Bilateral hip replacements, I do in about 10% of the patients. And it's a select group of patients in the healthy side who have equal problems with both joints that are candidates for both. It's not, those patients will spend 1 or 2 nights in the hospital. It's not that it's not safe to do it as outpatient, but it takes a little bit more than 6 hours to get up and get going after bilateral hips or bilateral knees.
Someone that's had a hip replacement in the past, what are some symptoms that they should recognize to know if a revision is needed?
I think that
everything's been perfect so far, so if nothing's wrong, not broke, don't fix it.
Yeah, I think when a person like that is doing very well at some point after surgery, it's pretty uncommon to develop any symptoms. The symptoms that we look for from a surgeon standpoint is actually something that doesn't cause anything for you. It's an X-ray finding of wearing out of the part, which you can only be seen on the X-ray and does not cause symptoms. So that's why we generally recommend a checkup every 5 years or so. If you as a patient develop pain around the joint and you're concerned about it, give us a call. I wouldn't necessarily make an appointment right away because that is a bit disruptive of your life schedule. I might call and talk to one of our PAs or nurse practitioners and just have a conversation with them about what's going on. You might find that a lot of the stuff, I would say 95% of the things you're going to feel are things that can be dealt with over the phone.
Person is questioning getting back on their Peloton after hip replacement. Is that okay? And how soon can that be done?
So I will talk about what I tell my patients. Now you're going to have to, if you're another surgeon operator on, you need to specifically talk to that surgeon's nurse and see that they agree with me. But I tell people the following, that the surgery is a trauma to the muscles. And if you traumatize your muscles, like in any sport, if you have a sports injury, your muscle swells up, it becomes a little bit less effective, and it needs a little bit of time to kind of heal and let the swelling go down. And that's what the post-operative first month is all about. And then once the swelling goes down, you can rehabilitate it more properly. And that's where the action comes in. So things like Peloton and starting sports and doing a lot of heavy stuff, I just tell the patient, give it about a month and just, if you really feel you're able to before that, that's fine. But I would respect the muscle healing process and give it a little bit of time.
Questions here. If COVID shot is required before surgery. To my knowledge, it is not, but we do COVID testing on all surgical patients prior to procedure. Do you have anything to add to that, Dr. Hozack?
Yeah, so our own people are we have one of our group is an expert on the infectious disease side of COVID, and he has said it's not an issue to have the vaccine ahead of the surgery. The protocols for the hospital, they each have their own protocol, so you still might get tested regardless, but I don't know what the actual answer is for each hospital.
Can you discuss briefly your hip incisions lie? This is a female that is asking about location and direction of the incision.
So you're asking about my personal ones, or you're talking about everyone? So there's different locations of incisions, right? Or different approaches. There's incisions that are based, if you're wearing a pair of pants with a crease on the side, like along the crease line, right? Of the pant, not the crease line of your hip, but that's a side incision. And there's a couple of approaches done through that location. And then there's an anterior approach is done more where if you have a pair of pants along the line of the pant incision, where the pocket might be. There's also a horizontal incision in the hip flexion crease, like when you bend your hip, there's a crease that you have, and you can make an incision there to do an anterior hip. And so there's a lot of different kinds of incisions that can be made. There's not one approach that necessarily gives a better long-term result. Each of the approaches have their different things going on, and if it's done well, the surgery can be recovered from quickly no matter what the approach. So I think that answers that question. A couple of different locations.
As far as steps, are steps always covered prior to discharge from any facility? Patient is asking, when will they be able to go up steps?
I believe the answer is yes. So I'm assuming that they teach you, but I stepped back a second and said, hold on a second. You know how to go up steps. I mean, you all do. I mean, before the surgery, you know how to do it. I mean, it's not complicated. Grab the banister, go one at a time, right? Up with the good, down with the bad. It's kind of how people do it. It's like people with bad hip arthritis or bad knee arthritis already figured it out. They know how to go up those steps because they struggle. They got to do one step at a time. They got to put the right, if it's a right knee, they kind of do it different ways. And after the surgery, you do it the same way. And then it gets easier. Simple. That's how it works. So you don't need to be told how to do it because you kind of know how to do it, but they cover it anyway.
Mm-hmm. Absolutely. Is neuropathy a possible side effect of joint replacement?
Yeah, yes, different kinds. There could be nerve injuries that leads to things like a dropped foot or numbness, or a leg that doesn't straighten out. But more commonly, there is numbness around the area of an incision or just beyond an incision. So if it's a knee incision, there's always numbness on the outside of the incision. If it's a hip incision, always numbness behind the incision, or especially an anterior approach where there's an anterior incision, numbness on the lateral outside of the leg a little bit. So there's always numbness associated with an incision because there are nerves in the skin that get cut when you make an incision. That tends to get better. Finish that up. Numbness can be bothersome in the beginning and noticeable. Not everybody does, but it does tend to become more tolerable over time. And usually over the first year, it becomes less of a patient stop talking about it. How's that?
Looks like we have someone who is 7 weeks post-op. They've been doing forced therapeutics. What would you recommend if they feel the need to switch to an outside physical therapy? And what are your thoughts on water therapy?
Yeah, if you feel, so the question I would have is what goals are not being met? Because at some point the therapy needs to be focused about a goal, right? Not just do therapy. So if there is a specific goal that is not being met by the forced therapy, then it's reasonable to have that discussion with the physicians, helpers, and talk about the possible need to do regular therapy, okay? In terms of water therapy, water therapy is fine. It's not really, what we're looking for after joint replacement is more strengthening and coordination, and that doesn't really do well. Water therapy is not a way to do that. So it tends not to be a major focus of joint replacement recovery. That it's not really, it can be done for other reasons, for arthritis in general and other reasons, but not for joint replacement recovery. It's not a primary way of doing therapy.
A few more people commenting on the dates that you've done surgery. So everyone, thank you for your comments there. We'll be sending all that to Dr. Hozack at the conclusion. Some questions with regards to robotic knee surgery. Just because we didn't get into that tonight, I know that is too detailed for Dr. Hozack to start talking about, but we do have some of our other joint replacement physicians that have pre-recorded lectures that actually are on our YouTube page. You can go youtube.com/Rothman Ortho and find some previous lectures that may be a little bit more specific to either hip or knee, and those that speak to robotics there, just because
I'll just make my own 2 cents on it. I won't dwell very long. I do robotic knee replacement as well. And you know, again, it's, I think you should, if you want to find out more, I would listen to the talks that have been put together. There's a lot of information on the internet, which is all good. It just doesn't have, you know, sometimes the internet doesn't give you a very good perspective. So I think I would encourage you to listen to the talks.
Thank you. A few other things we've talked about. Anyone that is interested in scheduling with Dr. Hozack can do so by calling us directly. That number is 800-321-9999. I will put that in the chat. You can also visit our website. That's rothmanortho.com. There are several areas on that website. You'll see it real big in bright yellow. You can click to make an appointment. You can simply fill out all of your information on that website there. And tomorrow, one of our representatives will call you to coordinate you getting scheduled with Dr. Hozack or with one of our other physicians. And that stands true whether you'd like to come to the office for an appointment or if you're looking to do specifically a televisit with one of our specialists with Dr. Hozack included. Everything does get scheduled through the same scheduling center here at Rothman. So either you can call us or go to our website and click to request an appointment, and someone from our scheduling center will be in contact with you tomorrow if you do the option through the website.
I actually looked like, will there be a scar after knee replacement?
Yes.
And I think the question is the answer I'm going to give. Well, of course, there's going to be a scar, but our goal is really to give you a nice scar. Okay. And we have our techniques. We've consulted with our plastic surgeons, and they've given us advice on the best way to close up the incisions to reduce the chance of a quote bad-looking scar. But some people heal differently than others, so you can't always control that. But there is a scar, but we do our best to make it as pleasant looking as possible. How long is a partial knee supposed to last in a 50-year-old? Yeah, you know, there is no way to tell you how long it's going to last. We can tell you that how long, I would say, how long are you going to last, right? We just don't know, right? We hope that it's going to last 10 to 15 years. That's what most people quote. So that's kind of the number that most people will tell you, 10 to 15 years.
This one says they're scheduled for knee replacement next month. How would you say it differs in recovery for knee replacement versus hip replacement?
Yeah, what I tell patients is hip replacement is a soreness in the recovery, and knee replacement, it hurts, all right? So there's a different quality of pain. And I think it's because the hip is a little deeper in, it's kind of deeper down in, so you don't feel as much, and the knee is, in general, tends to be pretty close to the surface, so you feel it more. I mean, the results are the same in terms of quality, but I think there's more work involved with the knee replacement because it just more, it hurts more. But it gets better, not like arthritis, which keeps getting worse. It gets better over time. That's the nice thing about knee replacement.
Yes. A few other things coming in the chat. Anyone that is post-operative and has specific questions for their surgeon, whether that be Dr. Hozack or another one of our physicians here at Rothman, obviously the best way to get them answered, again, like Dr. Hozack said, please call, speak with your surgical team so that a nurse or one of our nurse navigators can help direct you to getting the answer that you need to those questions. You can do so again by calling our general number. They will take a message to submit to that physician and nursing team. Or if you have your surgical folder, I know there's many methods of contact in that folder, whether that be the surgery scheduler you originally sat with or your nurse navigator or clinical team member with your surgeon. So any of these specific questions, please reach out to your appropriate surgeon and their team to get them answered to you specifically. A few questions here about submerging into water, Dr. Hozack. How long after surgery will you allow patients to submerge?
Is that called like swimming or something? I'm not quite sure
Yeah,
what that means.
swimming, bathing in a tub.
Yeah.
They even mentioned.
So our general protocol is you have a waterproof dressing and you can shower right away, right? We generally discourage pools and tubs for about a month until the wound is fully sealed. I'm sure that it could be sooner, but that's generally what we do. So that's probably the party line.
Okay. Again, some of these other questions as far as total replacement versus some of the minimally invasive procedures.
Well, what's the question? Because I can certainly clarify.
Yeah, please.
Because I don't differentiate much. I feel that we do less invasive joint replacement now. That's why patients are able to go home on the day of surgery. So we are actually doing less invasive, minimally invasive surgeries compared to what we did 20 years ago and 30 years ago. But there's always opportunities to improve upon it. And so, you know, I think we're already doing it as a Rothman Institute.
Great, very well said. Looks like the other ones that came in the chat we have answered previously in some capacity. Any other ones that you're seeing in front of you, Dr. Hozack?
So you do hip and knee replacement the same leg at the same time. And yeah, yes, you can. Generally though, what we do is the hip replacement first and then recover from the hip replacement and then evaluate whether the knee continues to be a problem, because sometimes the hip is really the problem and the knee is not as bad as you think. So it's probably not the best way to do it on a regular basis. So, and if we're going to do the knee, it's probably going to be about 3 to 6 months before you can figure it out. So that's generally what happens. And then can you have a anterior hip replacement after hip repair? I think it may be a hip fracture or maybe a scope or something like that. And the answer is yes, depends on a couple things, but the answer generally is you can do a anterior hip replacement after many different operations, but there are some exceptions. How long between surgeries if you need both knees replaced and you don't want them both done at the same time? And that's a very common question. My experience is that patients need a bit of time to recover both physically and emotionally from a surgery. In other words, it's not like, okay, I'm going to have this surgery and then 3 weeks later, I'm going to want another one. You don't really want to do another one right away. You're not really physiologically ready. So my experience is sometime between 3 and 6 months, most patients are thinking about whether they want to do it again. And now some patients, for example, if one knee is really bad and the other one isn't so bad, and we do the bad one, the other one doesn't hurt, it gets better too. So, but I would say it's going to be 3 to 6 months before a patient is really physiologically and mentally ready to have another operation. And if you have both knees that are arthritic and they're both equally bad, what's the best way to do it? One at a time or both at the same time? And that depends on how old you are, how healthy you are, and how heavy you are. There's a couple criteria. So it depends, okay? So that's where you would have to talk to the individual surgeon about that.
Dr. Hozack, can you go over differences between male and female replacements?
Yeah, I think, well, that was a topic that was a big deal back about 20 years ago. And what it came down to was, what we're trying to do is individualize the operation for each patient, whether they're male or female, because each patient has individual needs. So 2 men don't each have the same need. two women don't have the same, men and women. Everybody's got different needs. So we're individualizing the operation for every patient. So it came down to that, and you have to have the right types of parts and sizes and techniques to deal with that. The companies have made parts that would fit anybody, depending on, and we're flexible enough to be able to do it for anybody and individualize the operation. That's really what that's about. It's not really a male-female thing. It's each person gets their operation that's correct for them.
What is the most frequently used knee replacement by brand?
Each company says theirs. How's that? There are, I would tell you, if you were to line them all up next to each other, each company, there's like 5 big companies that make the majority of the knees. You wouldn't be able to tell the difference. They're all basically the same. They market them to make them seem different, right? But in fact, because people's knees are shaped certain ways, and the knee parts have to fit the patient. So surprisingly enough, they all basically look the same. They're made of the same material, and they all are very, very well made and will last a very long time. So I don't think there's any real difference between them all. And I like the ones I use because of the instrumentation, but every surgeon has their own preferences, but I don't think there's substantially much difference between any of them.
Okay. I did include in the chat, as I said, for scheduling or to get in contact with your surgeon and their team, our phone number. And I also put the link in there if you'd like to request an appointment via our website. Those two are right in the chat function there. I would like to thank everyone for joining us this evening. Dr. Hozack, thank you. This was very informative. If there is anything else, again, everyone will be receiving an email over the next couple of days with this recording. You are able to reply to that and submit any additional questions you may have, or if you need any additional assistance in scheduling an appointment, you can also do so. Thank you all for your time and have a great evening.
Yeah, I enjoyed being here tonight and hope everybody got their questions answered and learned something.